Good afternoon, everybody. My name is Garrett Schmidt, and I am the managing editor for ACO Exhibit Hall. And I'd like to welcome you all to today's webinar titled How to Achieve Success in Your ACO Using Consulting and Technology to Your Benefit. I think this is going to be a really engaging topic, and we'll give you some insights and some best practices on how to do that. A few housekeeping items before we get started here. All attendees have joined the webinar today in listen-only mode, so you don't have to worry about muting your microphone. It's already been done for you. I would like to let you all know that the webinar is being recorded, so you can have the opportunity to rewatch the session, share it with colleagues, and we hope that you do. And I'm going to be sending out an email after the webinar to you all with a link to the recording and also a place where you can download the slides. So yeah, please share that and use that however. And during the webinar, we would love to hear from you. And our panelists, there will be a time for them to answer some questions. And so you will be able to submit questions at any time. You don't have to wait till the Q&A. You can do it at any time through the presentation using your little attendee control panel. And there's an area for questions on there. And those are also being recorded. So if we don't have time to get to all of the questions, we'll make sure to answer them all via email. So please continue to ask your questions. Finally, I wanted to introduce our presenters today. Kelly Conroy is the Director of Healthcare Consulting with Pinnacle, along with Kevin Newingham, who's also a Director of Healthcare Consulting with Pinnacle, and Amy Koch, who is Senior Business Consulting with Salient. And I believe Amy is going to be kicking us off, so I'm going to hand it over to her at this time. Hey, Amy.
Thanks, Garrett. So thank you everyone for joining our webinar today. I'm going to start with brief background on our speakers. So I'm honored to be joined by two people with tremendous experience in the value-based arena. Firstly, we have Kelly Conroy. She has over 30 years of healthcare finance and management experience and has even started the first Medicare ACO in the country. Their A number, I believe, was 1001. And they delivered almost $40 million in savings in its first year and continues to do so. She also continued to work with a number of other Medicare ACOs in the country, both privately owned and hospital owned, as well as independently owned by physicians. Next, we have Mr. Kevin Newingham. Kevin brings more than 25 years of healthcare research, strategy, marketing, and management experience, and has significant experience planning and implementing growth initiatives, and is recognized as a national leader in value-based arrangement spaces. And prior to joining Pinnacle, he was the Chief Strategy Officer for one of the country's leading public health systems. And then that brings us to myself. My name's Amy Koch. I'm actually the Principal Business Consultant, and what that means is that we work together with our clients, mostly accountable care organizations and MSOs, and some others who are in value-based arrangements. And we try to meld together our clients' needs with our solutions capability. And I have over 6 years of experience working with over 20 different value-based organizations. So together, Pinnacle and Salient have joined forces to deliver an end-to-end service to help your ACO move the needle towards success. And it can be very difficult to do this on your own, but with the help of subject matter expertise, you're going to get a team that has the ability and the agility to work with the administration on strategic approach, as well as the boots on the ground who are going to show you exactly how to execute your initiatives. This entire process is powered by the Salient solution, and that's what enables the consultants to actually drive accountability to your practices and providers that make up your organization. And we use the continuous process improvement cycle to quickly encourage change that's required to achieve programmatic success. So let's take a look at today's agenda. We're going to start out with brief backgrounds of both companies so you get a feel for the experience that these two companies are bringing to the table. We're then going to discuss the necessity for consulting in the ACO space. There's just so much complexity with a limited amount of time you actually have to prepare to take on risk, which could mean tremendous financial downfalls if correct action and plans aren't put into place. And then we're going to discuss how the technology component works in tandem with consulting and how evidence-based decisions are made. And then lastly, we're going to discuss our joint effort as a Pinnacle and Salient group effort to help your companies achieve success. So let's start out with Salient's background. Salient is known as a value-based performance management solution. And what that does is we actually are the data aggregators. We pull information from all different sources. And that could mean multiple payers data, so you're pulling the same information, claims, for example, from different payers, so it's different sources, or it can mean totally different sources like your clinical data versus some static reports and the like. So we're able to pull in all different data sources into one place, so we're data agnostic. And then what we do is we transform the information so it's actually usable and manageable. What that might mean is we're normalizing it. We're applying logic, whether it be CMS-based logic or maybe some proprietary logic. But nonetheless, we're able to create an environment where you're able to deliver knowledge in a timely fashion to the decision maker. And the decision maker in healthcare, especially in accountable care organizations, could be anyone from the administration who's trying to decide as a board what decisions to make, what initiatives to implement, or it could be people at your front desk in your offices who are doing scheduling and trying to figure out who to bring in for the next month for wellness visits. So we can really span the entire spectrum of users with the data we're providing. Salient has a three-prong approach here. We're not just a technology company. We do provide the software and we have a high-performance data mart, but we have a number of interfaces that help those different users get and make decisions as needed. So you might have data-savvy personnel in your organization, such as data analysts or even administrators who are just very subject matter experts. They get what the data is saying. They're comfortable with claims. So they might want a system that's a little more ad hoc, something like a sandbox. Whereas you might have personnel that just need to go into the system maybe monthly or quarterly, and they want prefabricated reports. We have an interface that addresses for both needs. We also have the application. That's where we add the logic and enrichments. And it's most notable that we follow a prescriptive methodology. And what that means is that we're actually aligning your data with your contractual needs. So when you complete your ACO contract, there's a lot of language in there that talks about being able to provide the information to your providers on a regular basis and being able to show people where the needle is moving, as well as understanding that there's components that Kelly and Kevin are going to talk about where you need to be able to satisfy your needs of quality, your spend, your utilization, and all that data has been arranged and organized in a way to help you fulfill your contracts. And then lastly, we provide a plethora of services. We, of course, will provide IT support. You forget your password, we're here for you. But we like to go a little above and beyond with analytical support. Am I doing this analysis right? Because you can use the data to get to the wrong answer very quickly. So we want to be there to help you make sure you're on the right path. So with that, I'm going to hand it over to Kevin, who's going to talk a little bit about Pinnacle.
Thank you, Amy. Just a few comments about Pinnacle. I did want to share, this is a map of our footprint across the United States. Our corporate office is located in Denver, but we do have offices in several major markets around the country. This is very helpful because it really allows us to be involved in projects with a variety of markets, but also a variety of organizations. When building our information base, this is very critical. Next slide. So Pinnacle certainly has a long history of developing and implementing value-based care arrangements. That may take the form of a startup, helping an organization that's just embarking on their value-based care journey, or working with existing organizations that are looking to improve operations or to deal with some type of a strategic or cultural challenge. Our strategy and operations division frequently gets involved in these types of projects. Sometimes these projects are very short term. We're able to come in and identify quick fixes. Other times they're more extended engagements. I know that our initiative that we're presenting with you today is a little bit more of a shorter focus, but certainly both Salient and Pinnacle are there to help you with longer, more substantial engagements if that need exists. We also have our coding solutions and our risk group that are very instrumental, help a lot of ACOs with coding issues and compliance issues. Coding is kind of the lifeblood of any ACO, whether that's the financial performance or ensuring that you're providing and coordinating the care of the patients that you serve. We get involved in a lot of those types of projects. We also have a medical advisory group that works with physician practices. Again, supporting a whole host of value-based care initiatives. And then both business and comp valuation services. So, we're in a good position to provide a host of services depending upon what your needs might be. And, we're there to kind of coordinate and bring to service, to bear the services that might be necessary. Next slide. So just a little bit about why we believe consulting is a necessity. Certainly third-party perspective, is a big part of advisory initiatives. We've all been in that situation where we're just too close to an issue. The whole adage of you can't see the forest for the trees. I think that's very real sometimes. If you're just too close or too involved in day-to-day operations, you might miss something that's very obvious. We actually see that a lot, where just having that third-party perspective can be very valuable. But again, as I mentioned previously, the ability to work with a variety of clients and work in a variety of markets, I think also adds to that perspective. Just having had the opportunity to see things, that might not have happened in your market. We also, it's not uncommon just the complexity of operations. For example, the idea of having multiple contracts with multiple payers, sometimes it's very hard to administer those. Again, depending upon, the other challenges that you're facing in your organization, it might be useful to bring in some support or an advisory partner with that type of initiative. I mentioned a little bit about the subject matter expertise. Certainly that is something that an advisory partner brings to the table. We believe we're well positioned to provide tips and tricks, if you will, those quick wins, things that we see frequently. The 45-day trial that we'll be presenting later today is kind of geared toward that. It's that opportunity to look at the information and identify if there are those quick wins. We also have identified several strategies that we believe are key to the successful operation of an ACO, and bringing that information to bear is another form of our expertise and how we support our clients. Change management, certainly change management is a challenge and often involves support. I think you're frequently looking at cultural changes. Those cultural changes might be individuals that are just struggling with the transition to value-based care. We encounter a lot of organizations on the health system side, for example, where there's a significant split in the commitment to value-based care. Some are there, others are more firmly entrenched in the traditional models of care, and working with those clients to sort through that and make sure that things stay on path is a big part of what we do. Data and technology is another area. That might take the form of working with your providers on issues around the electronic health record. Again, we mentioned the importance of coding, but the operation is only as good as the data, so ensuring that that runs smoothly. But it's also ensuring that the right indicators are being tracked, ensuring that the key performance indicators are being monitored and utilized for continuous improvement, are also very critical to, the successful operation of an ACO. These are all areas where we provide some support. I'm going to, at this time, turn it over to my associate, Kelly Conroy, and she's going to give some additional examples of types of consulting analysis.
Thank you, Kevin, and thank you, Amy. I'm really excited to be here today to talk about one of my passions, ACO consulting. So the first thing I want to talk about is quality and compliance. So we all know that accountable care organizations were created to move away from paying for volume and move to pay for value. So there's a huge quality component in order to receive shared savings. This is also true for the commercial contracts, and it's called a quality gate. To receive shared savings, you must know the metrics, the quality metrics. Like, for example, in the Medicare Shared Savings Program, ACO, there's 23 quality metrics in total. 10 of those can be done on a good annual wellness visit. 10 of those come from the CAP survey, which is patient and caregiver experience, and 3 are claims-based. You can use your data to see who has had an annual wellness visit and who has not. In my experience, even the best ACOs that have moved the needle from 10% of their population receiving an annual wellness visit to 70 to 80% of their population receiving an annual wellness visit, it's still hard to continue to do that every year. So you need strategies to keep it going, ultimately to improve quality measures, closing those care gaps, improving your MIP score, and coding. The next category I'd like to share a little bit of insight on is acuity scores. Some of you may know of it as HCCs, hierarchical coding conditions, MRAs, Medicare risk assessment, and RAF scores. Coding each patient's disease burden is extremely important in any value-based reimbursement model. All alternative payment models have some component of expected spend based on the health or the chronic conditions of the patient or a population versus the actual spend. This impacts their benchmark, their previous expenditures, a capitation agreement, a full risk agreement, and this is also true for commercial managed care as well. Your data holds the key to make sure these patients are accurately coded to reflect their actual disease burden. A stark example would be a patient aging into the Medicare program at 65 who's completely healthy, plays tennis every day, has never been sick a day in their life, versus somebody who comes in that's very sick and has carried the disease of multiple chronic conditions with them for many years. If they're not coded accurately, the Medicare and the people that actually set the benchmarks will see these patients as the same patient. Again, our strategies and our data can help you prioritize and bring those patients in. And don't forget that this needs to be done every year. The starkest example of the every year coding is an amputation. If a patient had an amputation last year and it wasn't coded again this year, then to Medicare and to the commercial payers, it looks like the patient's leg grew back, and we know that's not true. So next, I want to talk about membership. So there's 2 types of memberships, and it's the same for commercial, same theme for commercial. One is a prospective population health membership list, and one is a retrospective list. The prospective is basically a fixed list of patients that they believe receive plurality of primary services from your providers, and that list remains fixed for the entire life of the contract. A retrospective attribution list is one that changes every quarter. So you'll receive an initial list that of those they believe receive plurality of care from your primary providers, and then every quarter on a rolling 12-month basis, that list changes. And it can be a significant change if you're not paying attention. Amy will touch, this is different than assignables, and Amy will touch on that a little bit later. So you want to look at some of the best strategies for your providers and your population. Do they live in a place where they have a high percentage of snowbirds? Are there a lot of dual eligibles in this population? Do your providers have access to see the patients at least once a year and 3 to 4 times a year if they have multiple chronic conditions? And do you want to grow your membership, bend the cost curve, and improve quality? It's just some of the things you want to consider when deciding on what type of membership you'd like to be in. So as we know, Medicare provides all claims paid data on every patient in an ACO for 3 years and aggregated quarterly utilization expenditure reports. So you know where you can find the areas of greatest opportunity. But your claims data and Salient provide you with actionable information, such as who, which patient, which provider, who's in a skilled nursing facility or a home health high performance network, who's performing well in that network, who's not. Some other utilization metrics you may want to look at are inpatient days per 1,000, SNF days per 1,000, emergency room days per 1,000, and the emergency room admissions that lead to hospitalization. My favorite all-encompassing metric is the ambulatory care case sensitive condition. That's a mouthful. And this can be done, these are admissions that are admitted into the hospital with an ambulatory care sensitive condition, but they could be done in an ambulatory setting. And this is getting a lot of scrutiny from Medicare and from most ACOs in the country. And these are such things as hypertension and UTIs. Pinnacle knows what to do and can help with the rules and policy to figure out how to prioritize your strategies for a successful ACO. If you don't know the rules, you can't win. And learning as you go is costly. So this can all be very complicated and somewhat overwhelming, as Amy mentioned, especially with our new normal with COVID, as Amy mentioned in the beginning. That's why Pinnacle Healthcare Consulting and Salient have teamed up to provide strategies and actionable recommendations from our national experience with your data. So now I'd like to ask Amy to take us through the technology and dig into the numerous data points. Amy?
Thanks, Kelly. So the question is, I'm an ACO, you might be new, you might be an ACO that just hasn't truly achieved great success, and you want to get to point B, which is achieving success through shared savings, having high quality scores, and having your satisfied patients and providers. So how do you get there? And the answer is you're going to have to work with your team to implement initiatives, but you might not know where to even start. So with Salient, and it's something you should be looking for with your own solution if you have it, is that you have the ability to do this continuous process improvement cycle, which you see here on the left-hand side of the screen. You really need the capability to look at your data, identify your areas of opportunity, implement an initiative that is specific to those areas of opportunity, and then check and see, is it actually working? Am I moving the needle enough to be successful in this area? And if you're not, then you need to reapproach your strategy, which is why it's a cycle. Now, another important component in using the technology and giving transparency to the data to your actual providers and practices is what is called the sentinel effect, which is essentially by providing your doctors with scorecards or something that they could look at to track their own performance, they're going to change their behavior because they know people are looking at their scores. And that's the whole point of accountability. You're in an accountable care organization. Your practices and providers need to be held accountable, but they should be able to see their own data and make their own assumptions through it. So it's important that you have that functionality. Now, when teaming up with a solution, or if you're building it yourself, you have to understand that there are a ton of data sources. And this slide is intended to be a little bit overwhelming. I actually have 2 slides on data sources. And the point here is that there are so many different sources of data you need to pull into one place and manage it and normalize it so that you have a holistic view of what's going on. It's not enough to just have the claims. You need a lot more data points to create a complete picture. So the first 6 on this list, and these are just CMS sources here, are provided to accountable care organizations on a regular basis. You have your claims, of course. You have your expenditure and utilization files. Those are a little bit more stagnant. And those will help you identify your areas of opportunity, but you need the other files to help bolster that information. And the other 6 on the page are actually publicly available from CMS. Now, there are some other sources you might want to consider pulling into your system. And this might include your clinical data, whether it's coming from your EMR or possibly from your health information exchange. And that's going to differ by state. So I'm located in South Florida. Our HIE is primarily ADT feeds, admit, discharge, and transfer from the hospitals. I think there's maybe 95. I think they're getting a little bit better, but 95% of all the hospitals in the state are providing these feeds. Now, there are other states that provide more data. I've heard that Maryland is including skilled nursing facility information, possibly some laboratory information. So depending on your state, you're going to get a plethora of data points that you might want to pull in for that holistic view. You might want to consider pulling in your scheduling system, which could help you identify which patients need to come in or be seen. Or maybe you're trying to analyze no-shows because as an accountable care organization, you're in charge of the patient's safety. You want to better their care. You want to ensure that your patients are satisfied, and safety is a huge factor, especially with your Medicare population. well as your care management solution. So you might want to pull in that information, which is a combination of your clinical data. It's also more real time than your claims data. And then lastly, whatever source you have for social determinants of health. It could come from your EMR, but it could come from a survey or other sources that you're identifying within your community. So keep in mind that you need to pull in a lot of different data sources to get that full view. Now, once you have all that data pulled into one system, you need to start measuring things. You need to figure out where are your areas of opportunity. So of course, as an ACO, you have the ultimate KPI, and that's spending less than your benchmark by your minimum savings rate. That's how you're going to be successful. That's how you're going to reap the benefits. But we know it's not as simple as that. Kelly talked about how there's quality components. Of course, if you achieve shared savings, but you don't submit your quality metrics, you're not entitled to any of it. So you really need to make sure that you're focusing on quality, but it's not just quality. It's also your risk scores. It's also your utilization. It's all those factors that are components of your ultimate KPI. We have a complex ACO contract. You really need to know those rules. So that's why we look at a number of measurements, and this is where you'll pinpoint your areas of opportunity. So broken out into those same categories: finance, risk, attribution, quality, and utilization, you can see there's a number of measurements that you'll use to figure out, am I doing well or not? And you need to be able to break these out by your individual practices and providers, because you're drawing accountability down to those individual levels. If you look at everything at just the ACO view, people can be hiding and actually hurting you in that mix. You can't use group mentality. It's got to be individual providers and practices and figuring out exactly what those custom needs are for those groups. So these are some of those metrics we take a look at. We also like to look at percent change across a lot of them because it's improvement over time. The people who might be really high above your average number might be decreasing over time, moving in the right direction. And that's actually helping your overall organization. Whereas you might have some people that are hiding and they're actually much lower than your average numbers, but they're creeping up over time, and that's hurting you in the long run. So you need to be able to see what that percent change looks like. Now, there's some other measurement themes to keep in mind. They're not necessarily key performance indicators, but there's things that you need to keep track of. An accountable care organization for the Medicare space really doesn't have a referral system. We don't have a tight gatekeeper. You pretty much can go wherever Medicare is taken, and that's pretty much everywhere. So you need to figure out, how are you going to create your network? And I'm stealing Kelly's term, but she wants it used by everyone. So she calls it a high caliber network. And that's meaning that you're using a group of practices, providers, specialists, etc., who are providing high value. So high value at a reasonable cost. And that's going to be your high caliber network. And you need to be able to figure out who those players are. And you also need to make sure that that message is carried out so that there isn't leakage, so that patients are getting safe and appropriate care when they are needed. You also need a system that can take a look at your full population. So for ACOs, for those of you who are in retrospective attribution, that's your membership that you get on a quarterly basis, you'll basically see that you get a list of assignables. And this is the general population that your practices are seeing. There's a much larger population your practices are seeing than what's actually attributed to you. So getting information on this larger group can help you increase membership, but it also gives you insight into what the community looks like as a whole. So pulling in this information is going to be really great for your organization and will help generally increase your membership, but also help you with your population. And then lastly, we talked about this in the beginning, the idea of data aggregation. So accountable care organizations, some of you might just have an ACO contract with Medicare, but I would say the majority of you have Medicare Advantage or commercial ACO contracts. And you need to be able to pull all of this data into one place and compare them in an apples to apples fashion. You really need normalization so you can say, is this particular practice doing well across the board? Because I can tell you that the doctors are not looking by different payers. They're looking at their patients holistically. So you need a system that can pull it all in one place so you can make sure that you are executing your contracts as best as possible and you're achieving success. So once you've identified your areas of opportunity from those different categories, you'll put together a list, and there's usually 5 or 3 maybe that stick out that'll come to the top. And these are just some examples. You might have high ER utilization, you might have a high churn rate, or possibly low quality compliance, something along these lines. And you're gonna need to implement initiatives, and that's where our consulting group comes into play. So I'm gonna hand this over to Kelly, who's gonna talk about some of her experience and what she's implemented to help some of the organizations.
Thank you, Amy. So if you've identified a population with high ER utilization, it's either a lot of patients are going to the ER or a few are going very often. The first thing you may want to consider doing is a root cause analysis. That will lead to some workflow adjustments for sure, and some engagement of the staff, something we see all over the country. Who are these patients? Why are they going? Is it an access issue? Typically it is. An interesting metric for me, some of the initiatives that we've provided guidance on is how many patients are going to the ER during office hours. And we have seen it as high as 58% of the patients go to the ER during office hours. Very surprising, but you need tactics to figure out how to reduce that number and figure out why they're doing that. It's likely going to be some workflow changes, some staff education, some triage tools. Are the staff answering the phone with the right questions? This is particularly important with COVID. Patients don't want to go to the ER and they don't want to go to the office at this time. So is your staff providing education, telling them where they can be tested, same-day solutions, telehealth, social service, any kind of care coordination or navigation for their safety? A couple other ER initiatives you might want to think about are potentially avoidable initiatives. And there's an NYU algorithm that is in Salient that can provide that scorecard for you. And another one that I find extremely helpful is a patient education type initiative. And that's usually, we've seen that in like yellow light, red light, green light, when to go, when not to go. Typically patients are not trained when to go to the ER, and they are looking for that education now, especially with COVID. So the high churn rate, we discussed earlier the need for a strategy about what type of ACO you may choose. So the new Medicare ruling called Pathways to Success has 5 basic pathways, A, B, C, D, and E, the enhanced and the direct. And with that comes the prospective or the retrospective attribution, and you can choose. So if you choose retrospective attribution, you just need to be aware that the churn rate could be as high as 30%. Every quarter when you receive your report, you may not have lost many patients. It may even be off by 10 or 15. But if you drill down deeper in it, you will notice that 30% of your population went out of your ACO and 30% of your population came into your ACO based on seeing your primary care physicians. So it's really important to talk about. And if you can only imagine, if you're reconciled once a year, you'd want to have that patient in your ACO for 9 to 12 months so that you can do care coordination and improve the quality of their care and reduce any unnecessary expenditures. Imagine if you got an influx of 30% of the patients in the last quarter and you only had 90 days to work on them and provide good population health strategies. Let's see. Another strategy, and I think many people may know this, but doing annual wellness visits. We already mentioned how important it is for quality because you can meet 10 of the 23 quality measures, but it also counts for 1.5% or 1.5 times an office visit. So that's important to do that to keep the patients attached, or some people like to say sticky, to your ACO. Make sure you're calling and following up on follow-up visits. You know, every ACO we go into, we ask, do you provide a follow-up visit for every patient as they leave the door? They always say yes. When we dig deeper into it, it's 50-50. You also want to call on your no-shows. And, you know, this COVID crisis is really pointing that out. The people that are not going into the office, the ACOs are calling and checking on those patients to make sure they're safe. And lastly, you may want to deploy a snowbird tactic. And the snowbird tactic would actually work if you were doing it already. That actually would work very well during this public health crisis. Next is quality. So it's important to have data and to stratify and set up a high performance network, or as I like to call it, a high caliber network. And what you do to do that is you set up ACO expectations of excellence, and you publish those for the skilled nursing facilities and the home health agencies that like to work with you. You hold them accountable for certain quality metrics. One example would be readmission rate. So one of the worst case examples would be a patient that goes from an inpatient rehab unit to a skilled nursing facility and then back to the hospital. So this requires good communication with the PCP on the front end so that they can be part of the care plan. You also want to proactively reach out to vulnerable patients. Most ACOs are already doing that. That has served them very well during this crisis. There's a great initiative that I see a lot of ACOs do. There's no place like home. This has been a winning initiative for most ACOs, and just has become so important to keep the patients at home. There's a big initiative from Secretary Seema Verma to actually have the patients go directly from the hospital to the home and not into the nursing homes. We've all seen some of the terrible things that have happened this year on that. So those are just a couple examples of some initiatives, and I think I'll turn it back to Amy now.
Thanks, Kelly. And as everyone can see and hear, Kelly has a lot of experience, and so does Kevin, and they just have pushed these initiatives across a number of organizations. They know that these are proven tactics that are successful. So getting that experience is going to be key in moving your needle. Now, in terms of moving the needle, you need an actual dollar amount. You need to actually point out that what you're doing is making a difference. And that's why you need the data to circle back to say, okay, we pointed out where our areas of opportunity were, whether it's your ER, for example. And then you might implement an initiative. One of the many tactics that Kelly and Kevin could provide you with, for example, answering your own cell phone. I know a lot of you can't do that based on how you're set up, but that's just one example of a tactic. And then you need to be able to say, what does the data show me? What are our changes that have occurred? And that could even lead you to a decrease in ER utilization. You can see how much, for example, 8%. And then you can actually calculate what those savings mean. A decrease in a certain utilization category will mean a savings of X amount of dollars. And you need to be able to pinpoint exactly where that money is coming from, because if you're making savings and you don't know where the dollar amounts are coming from, then you won't be able to have repeatable success. That's not success. It's, kind of like by chance. So you really need to know the numbers and figure out what's going on. And the numbers don't necessarily need to mean only savings. You might actually be able to show numbers that are helping your practices. For example, if you're helping with churn and you're doing annual wellness visits, that's increased fee-for-service reimbursements to your practices. Show them that. It's enticing. It makes them want to do more. So you might be able to generate additional dollars to the practices through fee-for-service reimbursement, which ultimately could lead into a savings on another front. But you need to be able to draw those connections and calculate those savings and those financial wins. So lastly, it brings us to our joint effort that Kelly's going to run you through.
Thanks, Amy. So we have combined our strengths to help you out in the short term or the long term. We know you're very busy. So while you may be working on your COVID strategies, trying to get all of your providers on telehealth and trying to keep your patients safe and at home, we would come in and adjust your claims for 45 days and provide you with a customized assessment with new and renewed strategies and actions with the best opportunity for your best opportunity in quality, coding, utilization, engagement, and buy-in. I know what you're thinking. How big of a lift is this going to be? I'm very busy. It's a very little lift. Our team of experts will come in, take your claims and claims line feed data of 3 or more years. If you've been in 2 contract periods, it would be longer. And in less than a week, we can provide you with a customized and keen insights and recommendations. At the end of the 45 days, if you choose, there's no further obligation, but we aim to impress you. Next question you probably have is this expensive? Due to the 45-day free trial offering by Salient and the deep discount by Pinnacle Healthcare Consulting for this one-time customization, it's at a very nominal fee. Please feel free to reach out to us if you're interested. Amy or Garrett, is it time for questions and answers? Thank you.
Great. Thank you guys so much. That was a very informative presentation. And we do have some questions actually. And if any of you listening have any more questions, please continue to submit them and we'll try to get to as many as we can. All right, the first question, and these are in no particular order here, is what does the process look like after the 45-day risk-free trial?
Thanks, Garrett. I'll take this one. This is Amy. So the 45-day trial actually enables us to pull in all of your historical data, and it probably enables us to do at least one monthly data load. And going forward, since we already would have all of your data, if you provide us with a letter of intent, we'll actually continue to pull your monthly claims in, and as well as your other ACO reports, and basically pay a subscription fee. And you'll work with Pinnacle to continuously improve your processes. So a one-time 45-day trial will help you identify the first round of initiatives. But going forwards, you'll want to see, did we move the needle? If you did, what's your next step? Because there's always more you can improve upon. So you'll want to continue that process. You'll want to identify new areas. You'll want to drill down to the nitty gritty, which practices, which providers, how do we customize our strategy to make sure that certain practices are doing things. And everyone's going to be different. Every practice has a totally different setup. So you're going to really need to continue with the whole process as you move along. Kelly and Kevin, did you want to add anything to that?
No, I think that was perfect. Perfectly said, Amy. Thank you.
So, thank
Okay,
you.
great. Next question is, our ACO is taking a hit on fee-for-service revenue due to the COVID-19 pandemic. What are some methods you deploy to help our organization during the pandemic?
I'll take that one if you don't mind. So one of the things that, I take a deep breath and I think about it is this COVID pandemic has really shown a strong light on all of the efforts ACOs have been providing. So if you were an ACO that was actually receiving capitation checks, you would be receiving those same dollars despite the fact that all elective procedures and offices were closed. So that is one area that people are looking to improve if they already didn't have it. Of course, every ACO rushed to get their providers hooked up with telehealth and remote monitoring. So that's something that the ACO provided these fee-for-service providers. And then a proactive reach out to any longitudinal patients. We probably already knew about the patients that we wanted to provide longitudinal care on, but this was really helpful if we already had those lists and we were working on those patients. We were able to reach out to them, the people that were most at risk. So this really has enhanced and strengthened our need for care coordination efforts. Basically, it's really made the patients understand the care coordination efforts that we've been trying. So, and we've spoken to CMS recently, and they plan to double down on care coordination. They really feel that ACOs that had a strong practice of care coordination were really best suited to help through this crisis. So, of course, always there's TCM billing, transitional care management billing. And then you must know that, and some ACOs don't know this, but the telehealth component that is now being paid for by Medicare also pays for annual wellness visits. So after you've already taken care of all the patients that you're most worried about and at risk, then you want to go back through and get back on the wagon and do the annual wellness visit, because we're very concerned about the patients that are just not coming into the office because of their fear. And so that annual wellness visit is helping us find those people that may have a health crisis before the end of the year. And then lastly, we're advising them to rethink their workflows. This is the perfect time to do some pre-visit planning. Who should be in the office? Who's really sick? This whole pandemic has shown us that it really promotes a wellness model. If you're well, and in the industry, we call them the worried well, having a telehealth visit is a perfectly good thing for you. The people that really need to have eyes on and be seen in the office, this pandemic and this crisis has shown us that that's important. So we are really seeing the offices rework the efficiencies of their workflows and making sure their staffs are really trained on the triage questions. And even we're seeing some offices send their staff to a 2-hour course on contract tracing. I'm also in South Florida, and as most of you probably read, we are the epicenter. So contract tracing is a very needed thing in this area. Those are just a couple ideas.
Great. Okay, next question here, moving along, is what is one major takeaway that value-based organizations should have from this whole pandemic?
I'll take that one to start, but would certainly welcome others to weigh in. I think from my perspective, the basic foundation of value-based care is knowing your patient. If you know your patient, you're in a much better position to coordinate their care. We found that during the pandemic, those organizations such as ACOs that were really focused on knowing their patient were best positioned, to really respond to the challenges. Understanding which patients were higher risk and working to manage that care, using mechanisms like remote monitoring and telehealth have only become increasingly important during the pandemic, and we think will continue to be important moving forward. So that would really be, my biggest takeaway is just that focus on truly knowing your patient.
Thank you, Kevin. And this is Kelly. If I could just add, I also think the takeaway is patient safety. The patients have been so appreciative when we call them and tell them to stay out in their car until it's time for their appointment. It's just created a sense of confidence in the primary care physician's office or the specialist office. And I think the confidence during this time, if we do it right, will lead to loyalty, lifelong loyalty by our patients.
Very good. Okay, one more question here is, will Pinnacle, which is powered by Salient, be able to analyze which patients are going out of network and like where they're going, and are these patients using high quality physicians, et cetera?
Amy, do you want to take that one, or would you like me to?
Yeah, I'll start. So data-wise, absolutely. You'll be able to view your data by your networks, and we typically are provided document that tells you exactly who's in and out of your network. So the ACOs, it's going to be all of your tax IDs or CCNs, whoever's part of your actual ACO network. But if you're part of a clinically integrated network, or you formed some bonds with other organizations, you might have loosely contractual obligations to work with certain organizations, whatever your preferred provider network is, we'll be able to incorporate that into the system. So you could actually separate your analyses by your in versus out and your preferred provider network as well. And then you could see the different metrics. So what metrics are you taking a look at? Length of stay, average cost, but you might want to pull in some quality metrics as well, like readmissions. Kelly, do you want to elaborate a little bit about what you've experienced and what else you would want to take a look at?
Sure. Amy and Salient and I did a use case study last year on this, and basically it was fascinating to see when you took a look back at what the return on investment was for patients that stayed in the network, and actually what the additional savings was. It was amazing. I don't remember the exact figures, but I think if they stayed in our skilled nursing facility preferred network, which we had 8 or 9, I think it was an average savings of about $2,000 per patient. So, I think it's really wonderful to get the metrics and then find out, is it really working? I think that Salient also helped us identify who should be in the network. So that was another thing. And I know that, people on the phone may say, well, how does that work? Patients have choice. And it is true, patients do have choice, but when you're accountable for the cost and quality of their care, there's no reason that you can't talk to them and go to them and say, here's the people that are in our preferred network or high caliber providers, because they work with us. They communicate with us. They provide us timely medical records. An example of a really interesting nursing home is they would go into a system every day and they would look in who was in the ER. And if we had a patient in common, they would call the ER and say, listen, this patient just came from a nursing home, because you would think the ER would know that, but they don't in some cases. You may want to send them back if it's appropriate, because sometimes those admissions just turn into admissions because they don't know how to place the patient. So I think there's a lot of keen insights that you can gather out of the data, especially around a high-performing, high-caliber network.
Yeah, and pushing on that concept of safety. It's safer for you to go to a certain skilled nursing facility because we have integrated health records. They're actually able to make note of what you're allergic to, so you don't have to tell them as you enter the facility as a patient who's just been traumatized from a really bad experience. So emphasizing that safety is key, and that you actually are working with some of these preferred providers because of a reason, and there's a good reason, that's going to really help promote where your patients are going.
I want to add one more thing. So if you are an ACO that has chosen retrospective assignment or attribution, the dollars follow the patient. So one of the things Salient does very well is they have matched the attribution logic as close to Medicare's attribution logic as anybody I've seen, especially since it changes every quarter. So I think that's kind of important too, if you're trying to look for those downstream dollars and what happened to them.
Very good. We have a couple last quick questions here, and then we will wrap it up. The next one is, can you describe some initiatives that you have been involved in around improved coding and documentation?
I can take that one. So yes, we certainly can. So a lot of ACOs, the first thing that they'll do is they'll run a list. They'll start with priorities. So for example, you run a list of every patient in your ACO that has diabetes. And so what I'll say is we have 500 patients with diabetes and 70% of them do not have complications. Immediately, you know that that's not correct. So you would then take that list of patients. Hopefully you would have a coder, at least one, sometimes multiple would be beneficial, and you'd have that coder look into those charts and find out what's going on. So the most successful initiatives around coding is having a coder trainer. Not only does she look at the charts and make recommendations to the physicians, but she's simultaneously teaching the physicians which code to pick. So another example would be coronary artery disease with atherosclerosis. Well, apparently, if you don't pick the code that has atherosclerosis, then you don't get an HCC weight, and it doesn't look like the patient has coronary artery disease. So there's certain high cost categories that you start with, and then you work your way through. You know, another initiative that's really good, if you can do it, if you have the staffing and you set up efficient workflows, is pre-visit planning. Really looking at that chart, looking what has been coded, looking what should be coded, looking what documentation is required. So I would say the pre-visit planning and the post-visit review, those are two very, very successful initiatives if you have the staff to do it.
And just to add a little bit, the data is going to provide you with that information. So being able to see your risk scores as the whole organization, but being able to bring it down to the practice provider and then your individual beneficiaries is going to help you really figure out exactly where your problems are. And then you could sort it through your cohorts like Kelly talked about, and then also break it out by, well, what did you code last year? What are you coding this year? What's the difference? Or are your codes dropping? Like Kelly mentioned, an amputee, right? You miss that amputee code, you're going to drop your risk score, and that's going to be a problem. So you really need to be able to cohort your groups so that you can put forth these initiatives that Kelly talked about.
Okay, great. Well, hey, unfortunately, we are out of time. We do have a couple additional questions, but if you did submit a question, we will get back to you via email. And so go ahead. If you have one now, go ahead and submit it because we will get back to you. And thank you to Kelly, Kevin, Amy for a very informative presentation. That was very helpful. I know I got a lot out of it. And lastly, as we close out here, I wanted to encourage you all to visit the Salient Healthcare exhibit booth at acoexhibithall.com. If you go there and you find them, you can connect there with their team, learn more about them. It's pretty cool. You can go and look around and see what they have to offer there. And we would love to hear from you in regards to that. So lastly, on the last slide here, wanted to give you the contact information of your speakers today. So if you wanted to reach out to any of them to ask any questions or to contact them, feel free to do so. Thank you all for attending. We hope that you found today's presentation helpful and useful, and hope you have a great rest of your day. Please take care of yourselves and stay safe. Thank you.
Thank you.
Thank you.